Hey, welcome to Euronurse. I'm your host, Vic Sinise, and welcome to the show. If you're watching us live, great, glad to have you on board. Be sure to hit that subscribe button, and any questions that you might have, go ahead and use the link to get to the questions to give those out live. If you're not watching live, no problem. Go ahead and just go to our website at euronurse.com, and you can submit questions anytime you want on our Ask Euronurse button. We'll get those questions. If you submit them ahead of time, they may show up on the show. Otherwise, we'll try to get back to some answers for you. But it's the best place to go to look at all of our things that the show has to offer, especially the best place to go to check out all of our past episodes. And boy, we got 84 of those episodes to check out. Want to listen to us in your car? Go right ahead. Go to our Euronurse Plus area and go to our audio podcast and go to any of your favorite formats. We're available. If you're not getting our e-news, I don't know why you're not. Go ahead and subscribe on our website. We do use MailChimp, so your email address is never revealed to anyone else on the group. So you'll find out some really interesting information. It comes out every Monday. Now, this week, we're really glad to have a return speaker, Dr. Dean Alterman, who's going to be talking about something that's near and dear to him, sacral neuromodulation. So with that, we're going to go ahead and bring in all of our experts that we have today. Experts, welcome to the show. How's everybody doing today?
Good morning.
Good.
All right. So as I said, I'm Vic Sinise. I'm the producer of the show, and I've been a registered nurse for the past 40 years. Sometimes we open this up to some interesting questions. I'm going to throw our interesting stories, and I do have one that I want to throw out there. And for the live audience, if you've had this happen, let me know. So like I've been saying, I've been doing this for a long time. I just had a patient that we were doing a prostate block on, who while we were doing it, right after he got the block, said, suddenly my hearing's gotten really stuffy. I can't hear very well. And I've never seen that happen. We were using lidocaine. And again, the physician doing it, never heard of it. We were kind of puzzled about it. I looked it up online and saw there was some articles that dental procedure caused it to happen, and they said something to do with the auditory nerve and lidocaine causing it. So if you've seen it before, put it in the comments. I'd be interested, or you can do it online. Just send it in to me, because it did happen. And luckily, this urologist's wife happens to be an anesthesiologist, so we asked her when he got home, and she says, "Oh yeah, we see that because we added to propofol to make it not hurt so much." And she said, luckily for us, they just wake up and it's gone already. And this other patient did recover from it, so it did go away, but it was weird. So you never know what you're going to see. All right, Andrea, go ahead and introduce yourself.
Good morning. My name's Andrea Strong. I'm a nurse practitioner in Milwaukee, Wisconsin. I'm also the educational director for the Chicago Metro chapter of the Society of Urologic Nurses and Associates. I'm on the board of directors for National SUNA. I've been working in urology as a nurse or nurse practitioner for the last 14 years now, and I've done just about everything that there is to do in urology. And Vic, I had a thought that came up when you were talking about that patient who had a reaction to the lidocaine. I actually had my wisdom teeth removed as an adult. Do not recommend that. And I decided to just do local anesthesia. When the dentist was giving the injection, I suddenly had double vision. And
Wow.
Thank goodness I had just covered cranial nerves in nurse practitioner school. And I recognized that probably the actual fluid of the lidocaine had compressed one of my nerves and caused that double vision. So over the next 15 minutes, as the lidocaine was absorbed, my vision went back to normal. But it was a little scary for a moment. It ended up being just fine, but very interesting.
Yeah, simple little lidocaine. You got to wonder sometimes. All right, John, welcome to the show.
Good morning. I am passionate about helping urologists succeed so they can reach maximum clinical and financial success. To that end, I created the Thriving Urology Practice Facebook group, where we crowdsource practice management solutions for everyone's benefit. I frequently speak on the topics of coding, billing, revenue cycle management, marketing, and how to run your practices more efficiently in the era of declining reimbursement and rising practice overhead. Next month in April, I'll be at the Rocky Mountain Urologic Society meeting speaking about just those topics. And then in May of this year, I'll be at the annual meeting for the American Urologic Association, so I will see you there. I am John Lynn, a private practice urologist in Gilbert, Arizona, and I look forward to hearing Dr. Elterman speak today.
Yes, great. And let's bring in our guest speaker, Dr. Elterman. Welcome to the show.
Thanks, Vic. It's really great to be back on the show, and I'm looking forward to our conversation today. By way of introduction, I'm Dean Elterman. I'm an associate professor of urology at the University of Toronto. I work at the Toronto General Hospital, part of the University Health Network. It's the largest academic teaching center in Canada. It's a very big medical institution right in the downtown heart of our city. And I'm fellowship trained in functional urology and reconstruction at Memorial Sloan Kettering and Cornell. So I spent some time in the States. And now I work mainly in the areas of functional urology, particularly overactive bladder, neuromodulation, which is my passion. We're going to talk about that today, and new technologies for BPH. And you'll see us back from the previous episode, I think 55, we talked about that as well. So I'm really happy to be back today.
All right, great. Well, go ahead and take it away.
Amazing. Well, listen, we're going to go on this tour de force of sacral neuromodulation and everything that you may need to know about it. And then hopefully we'll have some time at the end for some questions. So as I said, I trained here in Canada as well as New York City, and I've been an attending urologist back at the University Health Network for a while. These are our fantastic large medical center in the heart of the city. And I'm quite proud that we were actually ranked the #3 hospital in the world just a couple of weeks ago. And that's also the #1 public hospital in the world. So it's a really wonderful institution that I get to work at. These are my disclosures. I'm a consultant, including for Boston Scientific, who has just purchased one of the neuromodulation companies, Axonics, as well as Medtronic. So let's just go a little bit about some of the definition. Remember, the main thing that we're going to be talking about is overactive bladder, but we'll also be talking about some bowel dysfunction, fecal incontinence as well. But the definition, remember, for overactive bladder is urinary urgency, the strong, compelling desire to urinate. It's difficult to delay or defer. You got to pee right away. It's associated with urinary frequency, rushing to the bathroom many times in the day. It could be described as 8 or more times in a 24-hour period. Nocturia, which is really, you can think of it as nighttime urination. And also urinary urgency incontinence, so urgency with the need to go and you'll actually have to leak some urine. So you'll remember the mnemonic, it's the FUN symptoms, F-U-N, frequency, urgency, and nocturia. So how common is overactive bladder? Well, if you look at the United States, it is actually more common than things like asthma, diabetes, osteoporosis, Alzheimer's. So it is affecting a huge swath of the adult population. And so it's very common that we see. We know that it's approximately more than 1 in 10 people will have the symptoms of an overactive bladder, and it has a very significant impact on quality of life. There's a risk of falls and fractures, having to wake up at night. There's a significant economic burden, both in terms of lost work, productivity, as well as the cost of diapers and pads and things like that. And so having even moderate urinary symptoms impacts your quality of life, very similar to even having diabetes or cancer. There is a spectrum of overactive bladder treatments, starting from first line all the way to third line. First line is going to be things like behavioral modification, fluid management, pelvic floor physiotherapy. Second line therapies are going to be pharmacotherapies. These are going to be our medications like antimuscarinic medications, also known as anticholinergic drugs, as well as the beta-3 agonists. And then moving on to third line therapies, we really divide it between types of neuromodulation, such as sacral neuromodulation or tibial nerve. We'll talk about that a little bit. Or what we even call chemoneuromodulation, which is Botox, botulinum toxin injection into the bladder. And luckily, because we have these third line treatments, we don't really have to do too much surgery like urinary diversions anymore for overactive bladder conditions. One of the big challenges that we have with OAB, overactive bladder drugs, is very poor persistence and adherence, meaning the majority of patients who start these medications will not be on them at a year or 2 years. And so the persistence rates, people staying on their drugs, is probably between 14 to 25% after a year. So one of the advantages of giving a third line treatment like Botox or sacral neuromodulation is that you don't have to worry about a patient taking a pill or forgetting. It's given to them and it's working once it's given to them. I want to do a real brief overview of some of the neurophysiology of the bladder, because it's going to make sacral neuromodulation just make more sense. So our healthy lower urinary tract requires neural coordination between your brain, the spinal cord, and your bladder. And you can think that you're sending sensory messages, like your bladder is full, through afferent signals with the letter A. Your brain interprets those and then sends down a motor response down efferent pathways with an E. And so it's this interplay between sensing what's happening in your body, interpreting it in your brain, and then sending a message back down to that organ. And we also know that patients have normal bladder function, will have certain appearances within their brain on functional MRI studies. And in fact, patients who have overactive bladder will actually have changes in the brain that we can sense on MRI studies. And so generally what's happening is you can think of the bladder as like a muscle, like a little small balloon, and it's very slowly going to be filling at low pressure. And those afferent signals stay low. It's nice and quiet. And only when the bladder muscle starts to get stretched do those sensing signals start to increase, like the volume on a dial of the radio. And that's when your brain starts to think, okay, our bladder's getting full, the signals are getting more intense, maybe we should get to the bathroom. The challenge and the problem with overactive bladder is that you have bad abnormal afferent activity. In other words, instead of that signal being increased when your bladder's full, you're having that signal increase at random times. So imagine your toddler has got their hand on the volume switch and they're going up and down, increasing the volume, decreasing the volume, and those signals get sent to the brain, and the brain is like, what's going on? My bladder must be full, and the result is a bladder contraction. And so when you see urodynamic studies, we see detrusor overactivity. We see the bladder squeezing before the bladder's actually full. So now we get an idea of how the bladder's working with the signals going up and down. So it kind of makes sense that if we can modulate, if we can change those signals through an electrical system like a pacemaker, then we can actually normalize some of those bad sensory signals. In so doing, we can normalize some of that abnormal brain activity, and then we actually can restore bladder function. And so by putting in the electrodes, the lead, to give that gentle stimulation, that modulation, the changing of the signal in the sacral nerve, we're actually normalizing and almost returning normal senses and normal function to the bladder. Now, when we talk about sacral neuromodulation, we have to remember that it's a third-line therapy. Remember, we talked about lifestyle modification, physiotherapy. We talked about second-line therapies being medications, and then third line. And when we look at third line, both Botox and sacral neuromodulation are equivalent. They are equally weighted, both in the AUA guidelines and the EAU guidelines. And so there is not, there's a bit of a misconception that you should perhaps try Botox first and then neuromodulation, but that's not true. They are both equal choices that patients can make. And what's really interesting, and I'm going to show you some recent data from us as well, is that there's a very high rate of discontinuation also of Botox. So patients go on to get Botox, but they very quickly fall off after a couple of years. And so by implanting a battery into the body, you're kind of getting around that drop off. So the indications for sacral neuromodulation are urinary urgency incontinence, so leakage of urine from an overactive bladder, urinary urgency frequency, meaning OAB but without leaking, non-obstructive urinary retention, so an opposite condition, as well as fecal incontinence, right? And there have been hundreds of thousands of implants done around the world. Now, there are two different systems. I'll go through them very briefly, but they've really advanced over the years. We've moved, Medtronic was the first to have a system called InterStim. They advanced to a smaller system you can see on the left called the InterStim 2. That has now advanced to a small rechargeable system called the InterStim Micro, as well as InterStim X. And I'm going to show you some of those pictures. So this is an example of a very small rechargeable system now. It's about the size of a USB thumb drive. And they are rechargeable with battery lives now lasting up to 15 years. The other thing that has really been a big advancement in the field of neuromodulation is their MRI compatibility. Both the Medtronic system and the Axonic system have MRI compatible leads and batteries. And previously, this was a big hindrance because a lot of patients with neurological conditions need MRIs, but they also have overactive bladders. So they couldn't get neuromodulation technology, but now they can. So it's really opening up the possibility for some of these patients. This is the new InterStim X, which has a 10 to 15-year battery life. And then the other company, of course, is Axonics, and they have a rechargeable system called the R20 and a non-rechargeable or a recharge-free that we also call primary cell, which is called the F15. And that is their like a keychain fob that you can use to increase and decrease the intensity of your stimulation. So you can see here, this is the 20-year rechargeable system from Axonics. What's nice about this is it only needs to be charged every 6 to 10 months, depending on the drainage of the battery. And it's quite easy to use. And this is the recharge-free system, which is, again, a nice 15-year battery, very small to put in, very simple to use. Patients can essentially set it and forget it with these non-rechargeable systems. So how well does sacral neuromodulation work? Well, in some of the earlier studies, it was anywhere from about 65 to almost 80% clinical success. And clinical success is about 50% improvement in symptoms. And we also know that this is true for urinary incontinence, urinary retention. And so it's really been proven over the last 30 years that neuromodulation has been around. It's not new, that it's very effective. What are some of the common adverse events that we have to counsel patients about? Well, they could have some pain or discomfort at the implant site, some new discomfort. There's a very small possibility that the lead could move. Now, there's little tines, like little barbs, that prevent that from happening. Of course, with any surgery, there's a risk of infection or some technical problems, or you can get some changes in bladder, bowel, or undesirable stimulation. The good news is that most of these things can be easily fixed with some changes to the settings or a very small revision surgery. Some of the newer data from the Axonics study, this was their sort of first study in Europe to show whether their rechargeable system worked. In fact, recharging was very acceptable, patient satisfaction was very high, and it really allowed us to move it to the market. Remember, I said that Botox and neuromodulation are considered equal when it comes to guidelines, and there have actually been some studies that compared these two therapies. And the takeaway is that there's no difference in how good these therapies are, the outcome of urgency incontinence episodes. So both Botox and sacral neuromodulation will be equal to each other with respect to how much reduction in urgency, how much reduction in incontinence there is. One of the other indications for sacral neuromodulation, aside from bladder, is bowel dysfunction. Now, I see both bladder and bowel patients. Some places in the United States will have the colorectal surgeon seeing the bowel patients, or urogyne kind of straddles the two. So there's a number of specialists who may be offering sacral neuromodulation. Fecal incontinence. If you think overactive bladder impacts quality of life, imagine fecal incontinence. It really does significantly impact quality of life. So people who have FI, fecal incontinence, have significant impairment with quality of life when it comes to lifestyle, coping, embarrassment, depression. It really does impact them a lot. We know that these cases can improve quite significantly with neuromodulation. About 40 to 50% of patients will be completely cured. And of course, their quality of life, once you give them a neuromodulation system, will significantly improve for sure. There have been a number of meta-analyses showing significant improvements in the number of incontinence episodes, improvements in quality of life, and the morbidity is actually quite low. I think that in terms of revision rates and issues with the devices, they're very much in line with other sorts of surgeries. So when we think about how to approach sacral neuromodulation, it's really straightforward in terms of an algorithm. Patient comes in for an evaluation. Of course, with bladder and bowel, you want to try first line things, second line things, conservative management, dietary modifications, medications. But the nice thing about neuromodulation, I'm going to speak to this, is that there's a trial phase that you can actually give them a test, a temporary pacemaker, and you can actually see if they respond to the therapy or not. So there isn't a lot of thinking involved around really diving deep as to whether someone is a candidate, because the best test is the trial test to see if they're going to have success. So there's two types of trial tests. One is sort of what we call a basic evaluation, or what's called a percutaneous nerve evaluation. This is often done in an office setting or an outpatient procedure room. You can use it with fluoroscopy or without. And the idea is that just under local anesthesia, you can put a small needle into the S3 foramen around the tailbone. We put in a temporary lead, and we leave it in place anywhere from 3 to 7 days. And it gets connected to an external battery pack called an ENS, external neurostimulator. And the patient simply wears it on a belt. The other option is something called the staged implant. And what this is you actually go to an operating room, you use fluoroscopy, and you put in not a temporary lead, a temporary electrode, but the permanent one that has 4 electrodes, those barbs that prevent it from moving out. And you leave it in for a little bit longer, even up to 14 days, connected to the external pacemaker. And if they get enough of improvement in their symptoms, typically we're looking for a minimum of 50%, then what you do is the first part's already done, the lead is in, and then you just implant the battery. And so those are the 2 ways of testing. Here in Toronto, my practice is really more of an office-based basic evaluation. I can do it in a regular exam bed or in my cystoscopy suite. I do it with no fluoroscopy. I simply use bony landmarks to feel and palpate where the S3 foramen are. I do it under local anesthetic, and we're really relying just on a sensory response. So I ask patients whether they feel a stimulation like a tapping or a vibration in the bladder or in the vagina or in the perineum, and we're able to know. Our success rate is quite high, and therefore we're able to go straight to implantation in the vast majority of patients, and they just have to go to the operating room one time where we will place the battery and the lead. But if they don't pass this basic evaluation, we can certainly do the staged implant to give them a different trial, a different opportunity. Like many things in surgery, technique is really important when it comes to the success of sacral neuromodulation. You can't just put the lead anywhere. You can't just put the battery anywhere. You need to optimize it. And this is what's going to result in the best possible outcome for our patients. So here's just a schematic, a cartoon showing the anatomy of the tailbone, the sacrum. There's these natural openings in the tailbone called the foramina or foramen. And you can see the angulation that we have to use to put the needle through one of these. It's like getting a bullseye with a dart. Not only do we have to get it through the right opening, the S3 foramen, but we actually have to be on the correct angle. And we also have to be in the superior medial aspect of the foramen, because that's where the nerve lives. So you can see here, here's one of my previous publications where we describe the technique. And you can see it's not just getting it in the hole, it's in the top inner quadrant of where we have to place the needle. So it does really make a big difference. What we do is we can mark out using either, again, bony landmarks or fluoroscopy to where on the skin would correspond to the openings in the holes of the foramen in the sacrum. And once we do that, we can actually then put in our needles. And you see, it's really important to keep the needles straight up and down. And we're really sort of hugging the bone. I don't know if you can appreciate, but there's almost like these eyelets. Those are the foramina, and we're really medial in them because is where the nerve is. The other thing we want to do is obtain the lowest opening threshold, meaning when we're doing stimulation, we want to see the response. And there's 2 types of response. One is the movement inwards of the pelvic floor, called a bellows response. And the other is the big toe, the great toe will dorsiflex. It'll turn. And you really want that threshold of movement to be at a very low amplitude. So you want to be close to the nerve so that you're almost whispering to it. You don't want to be shouting at the nerve because that means you're too far away. And so by having these low amplitudes, it tells us that we're close. Here, then we dilate the area with an access sheath, a dilator, and then through this, we're going to place the electrodes. And you can see there's sort of an optimal way that they're angled in. You want the top electrode, what we call the number 3 electrode, to be right at the inferior border of the bone of the sacrum. And so this would be an example of a good placement. And this is what's going to allow for really good stimulation and longevity of the battery as well. Now, you mustn't forget that where we put the battery is really important because that's also where the patient is going to feel it. You don't want to put it too high or too medial so that it's pushing on any bone. You want it to be comfortable for the patient as well. So that's also something really important that the surgeon needs to think about when placing. But by putting in a good electrode, by putting in with 4 out of 4 electrodes, giving a good stimulation, you're going to get good battery life and also more options in terms of programming. And when we talk about programming, essentially you can think of the 4 electrodes being like a positive and a minus, like a battery, cathodes and anodes. and you can change the configuration of where the little sphere of stimulation is going to be based upon the different combinations of those electrodes. So you can see there's essentially 7 different configurations that will move the stimulation up and down the electrode, interacting with different parts of the nerve. And there's a little bit of a trial and error to find out which combination is going to hit the nerve at the right spot to give the right amount of stimulation and the desired effect, which is improvement in symptoms. So you can see here, there's the nerve. This is the electrode coming down around it. And there's going to be one combination, which would be close to the bottom of the nerve, another combination as it moves a little bit up, and then some sort of more oval, elongated combinations that we can create. So these are the 7 basic combinations that we can stimulate the nerve and give us different responses. So in terms of patient selection, it's people with overactive bladder, fecal incontinence, non-obstructive urinary retention. As I always say, it's the best test is the test. The percutaneous nerve evaluation, that trial stage, is really going to tell you. If you have any doubt about whether a patient is a candidate, I would say give them a chance. Do the trial. You lose nothing by doing the trial. But really do scrutinize their reported outcomes. When they come in, look at their voiding diaries, ask them questions about how much they improved. Did it improve their quality of life? For sure. I live in a very big metropolitan city with people from various countries and languages. So you have to be careful about language barriers just to make sure that people are explaining and understanding very well. The other thing to be on a bit of a lookout is occult spinal cord anomalies. So remember, you need the nerves to be in their normal position in order for this to work. So if someone has something like spina bifida occulta, sacral agenesis, abnormalities of either the tailbone or the nerves at the bottom of the tailbone, they may not be good candidates, and that may not be recognized. So sometimes I'll get an MRI on a young person who's had lifelong incontinence because maybe they have an undiagnosed spinal cord issue. I would also give a little bit of caution to patients who have a primary complaint of pain. Pelvic pain is an off-label indication for sacral neuromodulation, and it can certainly improve pain in a lot of patients, but you just have to be careful about setting the patient expectations. The success is probably closer to 50%, and the effect can also wear off over time. There are some complications, as we said, about poor lead placement, poor battery placement, poor wound closure can lead to exposures and infections as well. Some challenges that you may experience, and I know a lot of nurses, nurse practitioners, physician assistants are very much involved with the troubleshooting, with the counseling, and with the programming of sacral neuromodulation as well. At least it's certainly in my clinic. And so some things that you might see commonly in your practice would be something like loss of efficacy. So patients will come in and they say, it's not working anymore. So you have to ask them, was it sudden? Was it gradual? Was it partial? Have they gone back to their baseline? Because it could be something as simple as they turned the device off and didn't realize it. Or it could be the battery is wearing down, or it could be that there's something has happened, there's been a breakage. Pain is something that, or undesirable stimulation. And you have to ask them, is it pain in the pocket where the battery is? Is it pain shooting down their legs, or is it pain in the pelvis? And you might be able to reprogram the system to get around that. And last but not least is technical issues. Is there a fracture or a migration or some sort of physical mechanical issue with the system? Now that we have rechargeable systems and non-rechargeable systems, you sort of have to go a little bit in depth with patients about which is going to best suit their lifestyle, right? Both offer value. It's really about patient preferences, their lifestyle, and their treatment goals. You could very roughly divide it between, say, recharge free, meaning no recharge at all. Maybe you give it to people who just is not compatible with their lifestyle. They're not going to remember to recharge. Maybe they're forgetful. Maybe they don't have the motivation. Maybe they're super busy and they can't do it. People who get a rechargeable system, maybe they're going to want a smaller battery size. So maybe people with a very low BMI, really slim and thin. Maybe they're younger or more technically savvy. But I would say now that you have these non-rechargeable batteries lasting 15 or more years, and the rechargeable batteries last around the same amount of time, the value proposition really has become much more close to one another. And so I think the decision isn't so different anymore. So I personally put in almost exclusively non-rechargeable systems because they're MRI compatible, they last just as long, and the patients don't have to remember to recharge or interact with them. I put this in just as a kind of an interesting article. For anyone who's been doing neuromodulation a long time, we had this dogma of teaching patients that they always have to feel the stimulation. You have to feel the stimulation. Well, we did a multi-center study not that long ago, looking at setting the stimulation level, the amplitude, at levels below where they could sense the stimulation. So patients were randomized to what's called the sensory threshold. Let's say they felt it at 1 milliamp. And then we went 80% of that threshold, so 0.8, and then 50%, 0.5. And amazingly, even if they could not feel the stimulation, they had the same amount of improvement in incontinence episodes. So this study really sort of changed the way we think about neuromodulation in terms of the sensation, the need to feel it. And so, for example, if patients feel the stimulation that bothers them or is uncomfortable, you can set the stimulation at a subsensory threshold, a sensation lower than what they can actually perceive, and you'll still get, in most cases, good response in terms of reduction in urgency and incontinence. This is another paper that we actually just put out in December. And what we did is we looked at patients who were getting Botox, more than 2,500 patients. And we looked at 18 months before they started and up to 36 months after their last coating. And we looked to see how many people continued on Botox and how many people discontinued Botox. And in fact, the amount of people who continued was only 21%. And the amount of people who discontinued was 79%. So essentially, only 1 in 5 people will continue on Botox. So you would think that all of these people who make it to Botox and who then decide to stop taking Botox should then move on to neuromodulation, right? Because it's the other third-line therapy. But in fact, we only found that 3% of continuers and 7% of discontinuers moved on to sacral neuromodulation. So those 80% of people who started Botox and stopped Botox, only 7% went on to go to sacral neuromodulation. So I think this is a really big challenge for all of us in the field of urology, is to be able to get the right treatment to enough patients. And I think there's a bit of a disconnect. I think it's important to really take time when we're talking to patients, especially about neuromodulation. It is a complex, not so intuitive, straightforward thing for most patients to wrap their head around. You have to draw a lot of analogies. It's like a heart pacemaker. Everyone's kind of heard of a heart pacemaker. You can kind of understand that if there's an abnormal rhythm in your heart, it's because the electrical signals aren't working. And you can put in a heart pacemaker to electrically fix that signal. And so we tell them it's the same thing with the bladder. So you really need to have a good in-depth conversation, have your analogies. I like to use a lot of examples, images from the internet, brochures, allow patients to go home, think about it, ask questions, and come back so that they really understand, because it's a bit of a commitment, right? You're getting this thing implanted into your body. Here's just an example of what I think is really helpful, simply just putting into Google Images or whatever search engine, various pictures, and you can really show people, here's what a battery looks like. Here is where it goes. There's a misconception that the battery, the IPG, either goes into the bladder or goes into the spinal cord. And of course, that's not true. So really just being able to take the time to explain patients about neuromodulation is helpful. I'm going to just shift gears a little bit to maybe what is the future of neuromodulation. We talked a lot about sacral neuromodulation, so direct stimulation of the S3 sacral nerve root that comes off of the spinal cord. But what's really interesting, and is going to be a huge explosion over the next couple of years, and it's already started, is implantable tibial nerve stimulation. So what's this all about? So the posterior tibial nerve is a nerve that comes down the inner part of your leg, the medial aspect. And it comes right down around the inner part of your ankle at the medial malleolus. And what's really amazing for those who want a bit of trivia is that if you look at ancient Chinese medicine charts, where they have all the different meridians and body areas, the inner part of the ankle was the bladder area. So they had absolutely figured out the posterior tibial nerve was in fact a target for acupuncture for the bladder, thousands of years ago. So there you go. Most of us are familiar with percutaneous tibial nerve stimulation, PTNS. This is where patients come in initially on a weekly basis. And then after that, it's on a monthly basis. And they sit in a chair and you put in a little needle through the skin, percutaneous, and it will stimulate that tibial nerve to go backwards, retrograde up, to affect change in the bladder. But what the idea is what if we could actually implant a little pacemaker inside the ankle? Well, it could be effective, we know. It's a pretty easy place to access, right? If someone just has to put their leg on a table to do a small procedure, it's minimally invasive, right? And I think it could often be what's considered the future of overactive bladder treatments, at least one of the options for sure. So when you look at the tibial, there's going to be wireless options where there's no external connections, this very small option. And then there's going to be two different kinds of battery. One will be a battery-free system where you're actually going to have to wear something on the ankle to give energy, give power to get absorbed into this small transmitter. So it works for small periods of time. And others will actually be a small implanted battery into the ankle as well. So the idea is you're going to create a lead. You'll put a lead under the skin next to that tibial nerve, and you're going to be able to send a signal through the skin or within the skin, depending on whether you implant the device, and it's going to affect change to that nerve. So here's just an example of the tibial nerve. This is the inside of the ankle, and you can see that there's going to be the medial malleolus, which is the bone on the inner part of your ankle, and then you have your tibial nerve, and next to that is going to be an artery and a vein. So for those of us who are going to be taking this on, there's a little bit of anatomy, but it is relatively straightforward. The other thing is that there's a layer of fascia that covers the artery, the vein, and the nerve. And some of the implants are going to go just below the skin, but above the fascia. And some of them are going to go below the fascia. So you're going to have to make a poke or a small incision to get closer to the nerve. So there are about 5 different devices that are going to be coming onto the market. Blue Wind, StimGuard, BioNest, those are all going to be below the fascia. And then there's the Valencia Ecoin and the Medtronic InterStim T that's going to be above the fascia. And so here you can see an example of the Valencia Ecoin, which is placed just under the skin but above the fascia, and it overlies the tibial nerve, and it creates this electrical field that's going to allow the stimulation of the nerve. And here's another example of the Blue Wind, which is a miniature wireless neurostimulator. So again, you're going to have to put in this little implant right close to the nerve, and then you're going to have this battery that you can put on the ankle, and it will send the energy through to transmit to that little antenna to receive it. So a little bit of a different system. Here's another example of something called the StimGuard, where you're going to place percutaneously the electrodes, and then there's going to be a wearable ankle system. And then lastly, this is the InterStim T. This is the Medtronic device, which is going to be actually implanted under the skin but above the fascia, and it could be recharged as well. The Valencia Ecoin is actually available. It's FDA approved. It's quite small. It's the size of a nickel, and it actually is a primary cell battery. So there isn't a wearable component. There's a tiny, tiny battery inside. There's no lead. So it's essentially just like putting a coin over that area. And it has a whole bunch of different components inside. There's a lithium battery. There's a bunch of electrodes. There's some housing, and it's able to do all of the stimulation in one unit. So in summary, I think that overactive bladder, as I said, is an extremely common condition affecting more than 13% of the population. More than 1 in 3 older adults have overactive bladder. There are major issues with staying on the medications that we have for overactive bladder. And of course, they don't work for everybody. So the idea of a third line therapy like Botox, and in this case, sacral neuromodulation, really improves quality of life and symptoms. We talked a little bit about how fecal incontinence is a really hidden condition. It can severely impact quality of life. Many of our urology patients will suffer from both dual incontinence, urinary and bowel. And it's really important when someone comes in with urgency incontinence, overactive bladder, to ask them and screen them about bowel symptoms because they may be a bit shy. And remember, if someone has dual incontinence, bladder and bowel, it might make more sense to give them a neuromodulation system because it treats both. Because if you only give them something for the bladder like Botox, you're leaving the bowel component untreated. So certainly, in my opinion, someone who has dual bladder and bowel incontinence would be better suited to sacral neuromodulation. Sacral neuromodulation has now been around. It's going to be the 30th anniversary this year. And so that's a really proven long-term track record. There has been a lot of innovation over the last couple of years. There are now MRI compatible systems, rechargeable systems. And what we've really learned over the last 10 years or so is this idea of optimal lead placement, being able to put the lead and the battery exactly where they need to be to get the best responses and to give us the best options in terms of programming. And of course, opening up the opportunity to have MRI compatibility is tremendous for so many of our patients who previously needed to have MRIs for spine or brain or other areas. So I think it's going to really open up the field to more and more patients. And then, of course, we're getting into the era of tibial nerve, which I think is going to be really attractive to patients. Perhaps it's going to be a step forward in terms of getting towards sacral neuromodulation, or it'll be a perceived less invasive option for them. So I think neuromodulation is going to continue to expand and grow. There's going to be wearable devices like socks. There's going to be new approaches in terms of different targets like the pudendal nerve. There's going to be sensing features where there'll be a feedback of a contraction or a nerve signal that's going to cause the stimulator to turn on or ramp up. And so I think it's a really interesting and exciting time in the field of sacral neuromodulation. So I want to thank again the UroNurse team and Vic for inviting me to give this talk on sacral neuromodulation. My warm regards from Toronto, Canada, at the Toronto General Hospital and the University Health Network. And I look forward to our questions and discussion. Thanks very much.
Yeah, that was great. I can understand your passion for this because it is such a need out there to treat these folks. And I think that all of us that have been involved in urology have noticed that Botox, although it works, there has been a big dropout. And I think patients get tired of coming into the office to have stuff done. That's the bottom line. I think that's why, medications drop out and things like that. Where, as you say, the implantable device is more permanent. So I'm going to kick off the questions here. I did have an outside question that came in, so let's start there. This one came through our Ask UroNurse. Nadine asks, is the neuromodulator effective for improvement of urinary retention? I think you talked a little bit.
But let's talk a little bit more about that. So what's really incredible is that sacral neuromodulation is treating opposite conditions, right? You pee too much and you pee too little. And so it really speaks to the fact that you are bringing extremes of nerve signals to a happy midline normalcy, right? And so to be clear, it's called non-obstructive urinary retention. So you can't have, for men, a big obstructing prostate and overactive bladder. You got to treat the BPH first. And if they still have overactive bladder, then you can give them neuromodulation. For women who have retention, you have to make sure that they don't have obstruction from, say, a big prolapse as well. So you need to make sure that they don't have pelvic organ prolapse or a cystocele. This neurological retention is much more common in women. So we have things like Fowler's and non-Fowler syndrome, and we don't really know why, but some women will just stop urinating. And sacral neuromodulation works great for them. In fact, the success rates for non-obstructive retention are the highest amongst all of the different categories. It's along with fecal incontinence, it could be very high. So again, the best test is the test. Give them a trial, see if they're able to void spontaneously, see if their post-void residuals decrease. But very much, young women who have like a Fowler syndrome type of neurological retention do really, really well. The ones who don't do so well with retention are older men who have high post-void residuals, atonic bladders, because the pathology is different. They have years of obstruction from an enlarged prostate. The bladder gets stretched out bigger and bigger and bigger. the muscle of the bladder, the detrusor muscle, gets thinner and thinner and thinner until it no longer squeezes. And those ones don't really respond to neuromodulation because the target organ, the substrate, the muscle, doesn't matter how much you stimulate it, it's just not going to squeeze because the bladder has become so weak. So there's a little bit of a difference of sort of neurological retention, more commonly seen in younger people, particularly women, and this other type of retention, which is more an atonic bladder in older men, which doesn't respond well.
Yeah, good point. I do see some questions coming in from our audience. So I'll bring that up. So Katie said, what is your experience with neuromodulations such as equine in those with vascular processes or diabetes or obesity in these distal locations with incisional healing?
Yeah, so the nice thing about the ankle is that it's often a thinner part of the body, right? Even in people who are obese, there's that little area of the ankle that doesn't get so much adipose tissue. That being said, people who have poor wound healing, poor vascular supply are going to be at risk of wound issues regardless of where you do the incision. And a lot of them have peripheral vascular disease. And so their ankles and the distal parts of their legs don't heal. So I do think that that is a concern. I don't yet know if we have enough experience to say it's a contraindication for doing one of these ankle implants. But one of the things that we're going to have to deal with as we do ankle implants is going to be ankle wound issues, whether it's an infection or a dehiscence or poor wound healing. And we're just going to have to manage that.
Great. Panelists, I'll open it up to you for any questions you might have.
Thanks, Dr. Altman, for that presentation. That was excellent. And I think it's really fascinating. You alluded to this ancient knowledge of this technology. That just fascinates me that they had all this knowledge so many years ago. I do have several questions. One is, do we know why Botox stops working over time?
I don't. So there's a couple things. I mean, the biggest reason why people stop coming back is not because of a lack of efficacy. It's exactly what Vic suggested, which is it's just tiring to, I mean, yes, it's only maybe 2 times per year, right? I have Botox ass on average 6 months, but it's, I guess, that repeated having to come back, get your bladder frozen or have the injection or have an anesthetic. Is there an issue of sort of what we could say habituation? Maybe to a small extent, but there have been some other studies showing that Botox works just as well year after year after year in responders. So I guess it's some people it'll stop working, but for others it will continue to work for a long, long time. But I do think the biggest challenge with Botox is just people tiring of having to come in all the time.
Got it. And then I commonly see patients who have fecal incontinence and urinary incontinence in my clinic. And in my setting, it's the cultural norm for GI to handle the fecal incontinence and for us to handle the urinary incontinence. But I'm often the first person that they're telling about the fact that they have fecal incontinence. What are the first line therapies I can teach my patients for that?
Yeah, so the first line therapies for fecal incontinence are going to be things like pelvic floor physiotherapy and biofeedback to strengthen both the anus, the pelvic floor, the whole surrounding area. There are dietary things, so there are foods that they need to avoid, right? So things that may cause diarrhea, cause loosening of the stool. And then they're going to want to have bulking agents. So these dietary modifications that they can take, like the word is escaping me now. I was going to say Bulkamid, but that's not it. These bulking agents that they can consume to make the stool a little bit more well-formed. But they don't have the same sort of options like OAB does, right? There's just less options when it comes to fecal incontinence. You want to make sure that their bowels are regular. So some people cycle between constipation and then they almost have this overflow of stool back up, and then they have bowel incontinence. So you actually want to give them some regularity. So give them some Restorelax or something so that they have sort of normal stools and they don't cycle between constipation and fecal incontinence. But I do think that the real advantage, as I said, with sacral neuromodulation is that you're able to treat both conditions. And there's a lot of evidence that fecal incontinence is really similar to the mechanism of overactive bladder. It's really just bowel urgency and bowel incontinence as a result of bowel urgency. There's these extra contractions of the muscles from the nerve signals, and that's why we stimulate the same nerve, the S3 nerve, and it fixes both bladder and bowel. So they're really analogous. And what's really amazing too is that there's been studies showing that even if the anal sphincter has a tear in it, so a lot of patients have had an episiotomy from childbirth, or they have a very thin pelvic floor from prolapse or whatever. Even if the sphincter is not intact, sacral neuromodulation still works. So it's not really working on the sphincter to contract. It's working more upstream on the nerves, on the signals that cause fecal incontinence. So it does tighten up the pelvic floor a bit. It does tighten up some of the muscles, but most of the action is higher up. And so you could even have an incomplete tear in the sphincter, and sacral neuromodulation still works. And they don't have to have surgery like a sphincteroplasty to tighten up the sphincter. It's not necessary.
Interesting. John, you have any questions?
Yeah, this is a huge market, this overactive bladder market. I think about $4 billion market cap. So I understand how Boston purchased Axonics and what's the other one? Axonics and Interstim. Yeah.
Medtronic.
Yeah.
Yeah.
I always there's no doubt that this is an effective technology. It's been around for decades. The problem is always financial toxicity, right? It's very well tolerated, very effective. How does that work in Canada? I know how it works in the US. How does that work in Canada? Because provinces provide the funding for a lot of the treatment.
So, every healthcare system is different, and I'm sure, Texas is different than California, and your Medicare is going to be different than your Blue Cross, of course. The way it works in Canada is that we have, just very briefly, we have a universal healthcare system like Medicare for all. Healthcare is free for everyone. There are no co-pays. You don't have to get additional private insurance to get to see a doctor or to have surgery. Sacral neuromodulation is covered under the public Medicare system. It goes province by province, like state by state. The major issue, at least that we have, is that there are designated centers that do neuromodulation, like mine, and we receive special funding from the government to do it. And so if another center in Ottawa, 3 hours away from Toronto, wants to do it, they have to ask our state government, our province, for funding to do it. So one of the challenges is access due to not a lot of funding. But of course, new programs are opening up all the time. Fellows are getting trained and coming back to Canada, wanting to start new programs. But in terms of financial toxicity to patients, there isn't any, thank goodness, because they don't have to pay anything. It's entirely free, which is great. The biggest challenge is just getting referred in. And once they get referred in, we take care of them. The other interesting thing, maybe, John, that you've looked at is cost effectiveness and sort of where the lines cross when it comes to Botox versus neuromodulation. So in the early years, Botox will be more cost effective because the cost of putting in a pacemaker is very high. But after probably about 5 years, those lines cross. And then over time, sacral neuromodulation becomes more cost effective because it's in the body for a longer period of time. And you're not having the cumulative costs of repeated Botox. And now with the batteries that are lasting 15, 20 years, those lines are really going to diverge quite a bit. So from a cost to the payer system, I think over the long run, sacral neuromodulation would probably be a winner.
Yeah, I have to agree. When you're looking at it long term, a long term, an implantable cure is probably going to be more cost effective. Let's be clear here. Nothing is free. Nothing is free. Even Medicare here in the U.S., we pay into it, and the Canadian system, for the provincial system, you are heavily taxed. So somebody's always paying for whatever service that you get. So nothing is quite free. I just want to make sure the audience understands that. And
Absolutely.
I'm also
taxes pay for healthcare. This
Yeah.
is true. Yes.
And I'm also very, very excited about the newer technologies such as eCoin and Revi. I have seen both, and Revi fascinates me, where you implant almost like a grain of rice, except it's longer, it's very thin, and we are asking urologists and urogynecologists to go into an area of the body where we're not used to operating. So I think that learning curve is going to be steep, but it's also MRI compatible up to 3T. And it's a tiny, tiny little thing that you just implant into the posterior tibial nerve area near the ankle. And then you have this external device that energizes it via radio frequency. So I think that's really exciting as well. And you don't have to access the near the central nervous system and all that stuff. So I think that's really up and coming, and is very exciting.
Yeah, I agree. I think it's going to be really attractive to a lot of patients, right? People are just going to see it. Maybe it's just less invasive. It's the ankle. And then for providers, for doctors, we're going to, maybe some people find the sacral isn't their cup of tea, but maybe they would be willing to learn to do an ankle. It's like a minimally invasive therapy, but now it's for bladder as opposed to, a bigger surgery. And I think it'll really expand the market, and it's quite exciting. But for sure, all of these companies and us as physicians are going to have to, do some courses and get trained in, it's going to be a fairly simple procedure, but we do have to definitely learn how to work on the ankle now.
Yeah. We did have one question come in. I think this may have been a patient question from Leanne. Botox has caused me to resort to self-catheterizing due to weak bladder, which my doctor has blamed as a side effect of Botox. So my question to you, though, is maybe you can discuss, these are known side effects that can happen with Botox. Interstims see it as much, or I know you can just turn it off. What's your thoughts?
Yeah. So, there are two main things that we always caution patients about when getting Botox. One is the risk of a urinary tract infection. Okay. And the other is the risk of temporary urinary retention. So remember, what Botox is doing is it's relaxing the bladder muscle. And in some cases, the bladder muscle gets too relaxed, over relaxed, and so weak from the effect of the Botox that they just cannot urinate. And therefore, they will have to catheterize for a short period of time. It's usually maybe a few weeks, and then the Botox will wear off, and then the bladder muscle, the power will regain itself again, and they'll go back. So it's never a permanent issue with respect to retention caused by Botox. Now, if patients have a weak bladder to begin with, and they have high post-void residuals, they are at increased risk of developing retention if you give them Botox. And so therefore, they may be better candidates to get sacral neuromodulation, because neuromodulation does not cause retention, doesn't weaken the bladder muscle. So if I have someone who has overactive bladder, but it looks like they also retain some urine and there's some weakness to the bladder, you might preferentially choose neuromodulation.
Great. Well, this has been a fascinating discussion. I really appreciate you coming on for this talk. I think we're going to have more questions coming up, and probably might try to get you to come back, because I think there's a lot we can talk about going forward in the future, especially this stuff with the tibial nerve. But I'm going to put a little thing in for next week's talk.
Dual treatment for bladder cancer using gemcitabine and docetaxel bladder installations represents a promising therapeutic approach in combating the disease. Bladder cancer, a prevalent malignancy, often recurs locally within the bladder lining, necessitating targeted interventions. Gemcitabine and docetaxel, when administered directly into the bladder, synergistically target cancer cells while minimizing systemic side effects. Gemcitabine disrupts DNA synthesis, impeding cancer cell proliferation, while docetaxel interferes with microtubule function, inducing apoptosis. This dual therapy not only eradicates existing cancer cells but also inhibits the formation of new tumors. Noel Vivering, RN, discusses the localized delivery of gemcitabine and docetaxel via bladder installations. Join us next week on uronurse.com.
So yeah, we're going to be talking about that next week, so be sure to join us. Thanks everyone who was part of the panel, and thank you all you viewers who were joining us for this live, and we'll see you next week. on UroNurse.
Bye.